I'll just. People in Community Connect, there's a very exciting session starting. If you want to move here, please feel free.
Hello, everyone. Good afternoon and welcome to this session. My name is Daisy Lekharu. I work as a TB advisor at the Global Fund, and we support the work of the communities. And this is one work stream which was supported through the TB Strategic Initiative, which is innovative approaches to find and treat missing people in TB, missing people with TB. And we had the COVID-19 pandemic, which had tremendous impact on our TB programs. But we also saw the role of communities, which was so critically important for the programs to perform well and to come back on track. So we had commissioned this study, which was led by GCTA and with other partners and stakeholders in 4 countries. And we have speakers who will be representing the different contexts and share with us the lessons learned. So this is about innovative ways of engaging with communities to improve the TB-related outcomes and how they were engaged during the COVID-19 pandemic. So I would like to welcome all of you to this session once again. We have a wonderful array of speakers here today, and I would like to welcome all the speakers today. Um, so the first speaker, as you all know, Blessy Kumar needs no introduction. Ms. Blessina Kumar is a health activist and a public health professional with more than 30 years of experience working with varied communities across India, Africa, and Southeast Asia regions. She's been working on building capacity for issue-based focused advocacy for affected communities and marginalized populations. She continues to be instrumental in pushing global health towards people-centered and right-based approaches. She's a member of the WHO Civil Society Task Force, co-chair India CAB, ICMR, CAB member Benefiting Kids, Unite for TB project, and also other committees globally. So Blessy, welcome you to present on innovative TB community service delivery during COVID-19 pandemic and overview and the process.
Hello, good evening, everyone. Thank you very much for joining at the end of a long day. Um, I'm really privileged to share the work of some of the people at the ground level and what they did to make a difference in TB. I have no conflict of interest. So, like Daisy mentioned, um, the strategic initiative of the Global Fund, the TB program, was looking for innovative models of community engagement and care and service delivery, especially around the COVID pandemic time. And we did a study in 4 countries, and I'll present very briefly about our work. We had great partners to work with, and the project was called Finding the Missing Millions, Innovative TB Community Service Delivery During the COVID-19 Pandemic. And the 4 strategic initiative countries were Cambodia, India, Indonesia, and Kenya. And the methodology was GCTA is a community-based organization with members of over 600 spread across the globe, most of them TB survivors themselves or people affected by TB. When we took this on, we sort of brainstormed and came up with tools for information gathering. We had semi-structured questionnaires. We did a lot of focus group discussions. We had in-depth discussions and key informant interviews. And the people that we engaged with primarily were TB survivors themselves, treatment supporters, community health workers, civil society organizations, managers and coordinators, NTPs from the ministries of health. We also met with WHO country teams, human rights organization, and we did a lot of field visits as well, which we thoroughly enjoyed being on the field with our community members. So I'm not going to go into this in detail, but the questionnaire tool was developed to gather information. The FGDs and the key informant interviews were conducted with patient supporters, lay counselors, peer support groups in different contexts. And we worked with India, Indonesia, Kenya, and in Cambodia through our partner Kana. And we also did some in-depth interviews that we felt were needed to put this information together. So from the transcripts, we got the responses and organized them into themes. And these were divided into 4 main themes. The first one was the pandemic begins, multiplying challenges in TB detection and treatment. All of us know how TB actually was pushed to the back burner because the human resource and the tools for detecting TB were all shifted in many of the countries for COVID. And the second section is best practices in TB community service delivery during COVID-19. The third section talks about value addition of community-led interventions for TB care, human rights and gender barriers faced by TB communities. So the report actually is formulated under these 4 main headings. And we also had key insights and recommendations for reversing the COVID-19 related effects on TB mortality, morbidity, and on the livelihoods of TB communities, where then how they were complicated. So this is the report that is available on our website, www.gctacommunity.org, and has all the details of the interviews and the analysis from that. And just before I close, what I want to say is that what we found, which my colleague will share about, is that people working at the grassroots level were absolutely invaluable for keeping the community services going. When everything closed, it was the people on the ground, the community health workers, the cadres from Indonesia, the lay supporters and counselors in Cambodia, the TB champions in Kenya that actually moved the TB work along. And we are really privileged to be working with them. And our last slide, all of us advocates are keeping this because part of our advocacy at this conference is also to ask for reduction of the diagnostic tools, ask Danaher and CEPHIT to reduce price. Thank you very much.
Thank you, Blessy, for giving the introduction, and thank you for leading this work in the different countries. I would like to invite the next speaker, Dr. Tiara Pakasi. Dr. Tiara Pakasi, welcome. Dr. Tiara is the National TB Program Manager, Ministry of Health, Indonesia. The National TB Strategy 2020 to 2024 uses a people-centered approach which includes evidence-based program planning, prioritization of problems, and determining appropriate interventions to end TB in Indonesia. And Dr. Pakasi is committed to that goal in her role as the NTB manager. Welcome, and welcome to the floor.
Okay, thank you. Good afternoon, everyone. So it's me again, Tiara Pakasi. I just would like to acknowledge that I have no conflict of interest. And as requested, I would like to share about the value and contribution of cadres to the Indonesian health system. First, I think this is a little bit of background and context regarding COVID-19 pandemic that disrupted our TB program, where in the beginning of the pandemic, we immediately worked together with civil society organizations and the cadres to support MTP to capture how the pandemic impacted our TB services. So we finally found that in the beginning of the COVID-19 pandemic, case notification rate decreased by 26% and treatment coverage decreased by 11% in Indonesia, signifying one of the most noticeable declines within high burden to TB countries reported by WHO. So this is already a collaboration that we did. And in the national TB program strategy, as I also mentioned yesterday in during the plenary, I think communities where cadres is included there are highly valued to our program. And in the TB strategy, especially the strategy 5, we increase participation of communities, partners, multi-sectors in our goal to reach the TB elimination. So the efforts, all the efforts include cadres, CSOs, TB survivors as part of our stakeholders. And at the right-hand side of my graph, again, that is the framework of our TB program, where to prevent, detect, treat, and incorporate it with promotion, we always involve and we acknowledge the role and the contributions of our cadres in these activities. So here are some activities during the COVID-19 pandemic. First, for the prevention, we know that we had this limitation to move, yeah. I forgot the term, but so limited but continued to provide education to people during this period through online text platform, yeah, very simple because I think WhatsApp is very famous among Indonesians, so we use that, and also a phone call. And then, of course, with the support of the PR community, the consortium of Penabulu and STPI, Dr. Henry is here with us, also provided education about TPT, yeah? So not only about the TB case finding. And also we educate close contacts of TB patients to do self-screening. Yeah, we have this Asmara TB application. Actually, Asmara means amor, falling in love, something like that. And so yeah, and then for detection, when nurses in PMDT hospital were sick due to COVID-19, so the RTB case managers helped to engage new patients to be recorded, and then yeah, some other activities went to the house of the patients or the presumptive cases to collect their sputums, and yeah, utilize Google Forms to support contact investigation. So we innovate. We adjust our activities with the situation that very limited permission to move around, and also accompany close contacts for further examination, etc. And here are some documentation. So the self-screen through Asmara TB application for household contacts. This is not, of course, this is not nationwide, but I think some areas have their own way, but in principle, it's about maintaining the case detection or TB education, treatment adherence, and also to motivate the patients. Also sharing information through WhatsApp group among TB patients and the health workers, health personnel, and also the cadres. So here is the way of doing the contact investigation during the COVID-19 pandemic. So it started with some, we made the guideline, yeah. So not immediately, but yeah, we had the guideline, the special guideline during the COVID-19 pandemic. And then again, the report the simple report through a WhatsApp application. And also after that, we have this contact investigation conducted outdoors. So yeah, outdoors of the patient's house. And we also, during the COVID-19 pandemic, we also managed to have this Lapor TBC dashboard. Lapor literally means report. And this community-based mechanism feedback of laportbc.id. This is a complaint website, yeah, or how the patients or anyone can, of patients or survivors can report and can complain, or sometimes in our terms can curhat. Curhat means, yeah, can talk heart to the health personnel. And more than 2,000 visits has accessed this laportb.id, and we had new users, and average visits of each visit duration of each visitors is approximately 3 minutes, and we had total registrants of 777. So I think those are some experiences that we've been through the COVID-19 pandemic, and it resulted that we only like went down 2022 and 2021, but in 2022, it was still during COVID-19 pandemic, but we managed to recover, and we did it together. All the people that I acknowledge here did the collaboration together. Thank you.
Thank you, Dr. Tiara Pakasi, for that wonderful intervention and sharing. Truly, Indonesia has really stepped up during the pandemic to do things differently and engaging with communities differently, and shown us and shown the world that it's possible to engage with communities to deliver better results. And we're really happy to learn from you and your context. I would now like to invite the next speaker, Dr. Henry Diatmo. Dr. Henry Diatmo has more than 19 years of experience working in the health sector, along with, together with NGOs and also the government, and many of them have been focusing on tuberculosis control programs. He has a master's degree in public health and is a medical doctor. He has wide experience in program management, especially tuberculosis programs. He was able to form relationships with local governments through involvement of different partners. His experience in management, design, and implementation of strategic programs in the health sector and also other areas over the years have improved in helping Stop TB Partnership Indonesia in strategic planning and also developing organizational goals and achieving them. Under the strategic direction of the Board of Trustees and Advisors, he was appointed to lead the organization in setting and also achieving the ambitious goal to end TB by 2030, and we are still hoping that we should be able to end TB by 2030. Over to you, Dr. Henry Diatmo, for your intervention. Thank you.
Okay, thank you so much, Daisy. Good evening, everyone. It seems that I only got 4 minutes, so it will be fast. Thank you for the opportunity to stand here and represent what we have done regarding the situation of the pandemic for the community. First of all, my name is Henry Diatmo. I'm the Executive Director of Stop TB Partnership Indonesia. I declare that this presentation of the data, there's no conflict of interest. And the title of my presentation is about how the healthcare workers closing the service delivery gap during the pandemic. Maybe this is a little bit background, as mentioned before by Dr. Tiara, that after the pandemic attack our country, the notification is decreasing almost 20%, mostly, and it affect everyone that not just for the patient, it's also with health facilities. So TBPMDT Hospital became the COVID-19 referral hospital, and then the formal healthcare workers must prioritize to the pandemic response, and also the volunteers of healthcare workers need to support them. And also the physical mobility limitation to healthcare facilities and to conduct home visit. There's a big problem because mostly the cadres cannot do the home visit during the pandemic. Uh, in the right side, you can see number one is the Puskesmas. Puskesmas is the public health centers. And also the hospitals depend on the volunteers and to ensure that TB service continue during the pandemic. And at the above, the commodity healthcare workers in Indonesia, define of cadres, also the drug TB patient supporters in the hospital, and also the case medias for drug resistance TB. And one of this picture, we are gladly thank you for GCTA to support and collaboration for this project. This is our what we are facing at the pandemic or in the COVID. First, decrease of the contact investigation, which is mass TB education and activities. People with symptom of TB were afraid to getting diagnosed with COVID-19. So they're afraid to go to the hospital or healthcare facilities because if they just got a cough, it seems that almost the patient who attend to the health facilities must be the testing for the COVID-19, and usually they got positive COVID-19. That's why everyone seems afraid to go to that. And then the public perception of the healthcare facilities are high-risk location. That's why some of the home-based sputum collection being done by cadres and using a proper PPE and also a cooler box, because the problem of send the patient to come to the facilities, that's why the cadre have to come to the patient. And some people with TB lost their income because mostly TB patient cannot do anything. They have to be isolate in his home or in her home. That's why their income is very that's become a problem. And also the longer testing time labs occupied with C19. And the other thing, I think 35 seconds left. One person with duct resistance TB rejected treatment due to side effect. That's why the leverage of the volunteers community healthcare workers network to ensure that people recently enrolled in the drug resistant referred back to their nearest health facilities. Mostly of the older patients do not have or cannot use the smartphone. This is the one problem. If when we get pandemic, usually we are using the mobile or digital phone. But the older patient, I think, is quite challenge for them. Out-of-pocket expenses is also appears by cadres to support the patient facing financial hardship. So what I have during the treatment, routine calls being done to talk about the treatment and non-medical challenge, and also to deliver the medicine to homes and could bring longer take-home doses. And when the rehabilitation opportunity that need to pay attention to how people with TB could be more prone to post-TB lung disease. I think that's all. This is our acknowledgement that we are from the PR of the community from Global Fund, and our partners is Ministry of Health. Thank you.
Thank you, Henry, for sharing your perspectives. This is very interesting for us to know. We will have some questions for the panelists, but I'm waiting for the presentations to finish, and then we can have questions from the audience and also some questions for the panelists. I would now like to invite someone whom you all know, Evelyn Kabuchi, who is representing Stephen today, who was not able to attend. She will be sharing with us on the contribution of TB champions to TB care delivery during the pandemic in Kenya. So Evelyn, we are ready to hear from you.
Good evening. Good evening. Thank you. I'll start my presentation with a challenge. So you go back home from Paris and you realize you left your house when there was no water in the taps, but you didn't close the taps. And then the water came when you're away here for a week. So when you go, you find water streaming outside your gate. Who do you call first? Olive, who do you call first? Your plumber. More water will be flowing before the plumber comes. Thank you very much. Your neighbor first, right? So this is exactly what happened when COVID came. When the health system could not manage to address the issue, they called on the neighbor, who are the community healthcare workers, who they never knew. I bet you don't know your neighbor, right? Yeah. So these neighbors, the community health workers, they were not recognized. They did not know them. But this time, they had to talk to this neighbor to help them clear this water that's been pouring when you're in Paris. So what happened in Kenya? When the first case of the pandemic was reported, I remember that was on about 19th of March, 2020, because I remember we were planning for World TB Day when that breaking news came. There were so many challenges that came with it. First of it, the first challenge was that of course, there was the lockdown, and the healthcare system now concentrated more on COVID, ignoring most of the other medical challenges. Majority of the facilities were turned into isolation facilities for COVID-19. Healthcare workers were deployed to manage COVID-19, leaving the TB patients with no services. There was a lot of stigma. You could not cough in peace. You coughed. In Kenya, I don't know whether the other countries were like Kenya. If you coughed, the person who had you cough had the responsibility of calling the police, as in the police, to come for you, and the police would come for you in a police car. Okay? So people refused to cough. And there was an assumption that every cough is a COVID. And of course, once they came for you, you're forcibly isolated at your own cost. So people do not want to be isolated, so you'd rather not cough and just remain in your house. That was such a big problem. And there was limited testing for TB because most of the laboratories, of course, were converted, or the priority was COVID. And even when testing happened, there were delays, again, because all the efforts were taken to COVID. There were curfews, limited people's movements, and affecting adherence, as some clients were not able to go for refill in the facilities. I remember there was an announcement that we shouldn't go to hospital unless you're going for COVID. Just imagine that. So what happened is that most TB patients could not go for services. Even when you had a cough and you could think you have TB, they could not go for hospitals. They could not go to hospitals because we were told the health facilities were only for COVID. So what happened? One, the community health workers were called upon to support in delivering the drugs for the clients, so they could go themselves, bring the drugs and take to the clients in their homes. Of course, that posed a risk for them because by then we didn't even have adequate PPEs and we didn't have enough adequate education around COVID. Sample collection for those with the signs and symptoms at households. The sample collection was done at households and delivered to the facilities by the TB champions. Again, still no adequate PPEs and no adequate education on how to protect themselves. Health education on the difference between TB and COVID to reduce stigma. Yeah, it was inadequate. There was mobilization of food food support from partners like Red Cross. NEFAC is the network of persons living with HIV, and among others, for TB clients who are not able to go to work due to lockdown. Again, this was done by the TB champions and community health workers, mobilizing food to support those people who are on lockdown. And there was a lot of violation of human rights. Like I said, forcibly being taken to hospital, being isolated against your wish, though it was a protective measure, but there was so many cases of human rights violation, and there was a need for legal support, and they were linked to an organization called Kelin that does legal support for around health issues. So what recommendations are we making? One, there is need for implementation of strategies that are aimed to improved quality for TB care, and through use of new technologies. In other words, we are really advocating for adoption of the new technologies to improve quality of care, provision of adequate education for TB to the general population, recommending monthly TB screening for communities. This is to increase case finding. And to address TB, of course, we keep saying TB is a social disease. It only becomes a medical problem once the person hits the frame of the hospital. Before then, it's a social disease. And therefore, we need to invest more in the social component, much more than the medical bit, because that's where we are going to prevent and also get more people with TB. And there should also be meaningful engagement for TB-affected communities in the entire spectrum of TB response. That means programming, policy development, implementation, evaluation, and even in investing in them, so that we don't treat them as neighbors who we run to. We don't even know their names. We need to be known by name, okay? And we also need to invest in community-led interventions, and this community-led monitoring, and they should be done at the community level, not at the facilities, okay? Yeah, and like at the introduction, I've done this on behalf of Stephen Anguva. Stephen Anguva is a coordinator of the Network of TB Champions. Network of TB Champions, the secretariat is Stop TB Partnership, where I work. And so we helped establish this network of TB champions, and so we work closely with them. So I hope I've represented Steve Anguva very well. I know he's going to be proud of me. Thank you so much.
Thank you, Evelyn. And for those who don't know about Evelyn, she's been a global health advocate with a key focus on tuberculosis for more than a decade now. Since 2015, she's served as the Chief National Coordinator for Stop TB Partnership Kenya. She's also the advisor for the African Parliamentary TB Caucus and a member of the Civil Society Task Force in the WHO TB team. She's a board member also of the union. So we already have the next speaker there. I'd just like to introduce Ms. Archana Oinam, who's a public health professional and has worked extensively with marginalized and vulnerable populations for more than 2 decades, with attention to working closely with policymakers to inform around gender dimensions. Her areas of experience and expertise include strategic planning, program management, capacity building, advocacy and research. She's conducted many studies and published several reports, papers related to women who use drugs, HIV-positive pregnant women, and children using drugs. At present, she's working with the Global Coalition of TB Advocates on global TB, and she's been part of the team who has actually done this work along with Blessy and the other stakeholders in 4 countries. So welcome, Archana, and happy to hear your perspectives from the India experience on engaging with communities and in the COVID-19 era.
Thank you, Daisy. Hello, everyone. So I would just like to start the session saying that I have no conflict of interest. So what basically I'll be doing over here is like I'll be consolidating the points which everybody has spoken about, and I think Blessy has said in her presentation that this was a findings which this was a study which we did in 4 countries, and actually the methodology was qualitative methodology that we adopted, and we had like we collected we had in-depth interviews, and we have FZDs with many stakeholders. And we had so many informations while doing the analysis. We had so many informations, and we decided that we will categorize it into 4 thematic areas. So the best practice in TV community was one of the thematic area that we choose to do the analysis. So what Ibu Tiara and what Henry and what Evalent and what they have shared is the best practices that was done by the community. So these are some of the practices that, which we found out from the study, like how the community workers or how the community workers were actually, everything was locked down at that point of time. But what happened is that they come up with all kind of innovations to make sure that the services were not disrupted. They come up with the innovations like, trying to link it up. Like as you can see that if you look at all these services, you can see that it's a mixer of public-private partnership, it's a mixer of community engagement. So it's all through the spectrum of care that you can see that the community has been trying to give the services as required. And among all the 4 countries, one of the major thing what we realized, what we found was that WhatsApp calls or connecting the people, because everything was locked down and there was no way that people can go and meet in and all. So this was one of the medium which was really used. Vikas is also here. He was one of our stakeholder whom we interviewed. And actually TB Alert in India, they started a call center specifically during that period of time. So that there was very similarly, and like take-home doses was started. And then in Cambodia, I think they came up with the idea of linking up with the microfinance and coming up with the equity card, so that the direct bank transfer can be given to the people in need. I mean, it was not a huge amount as such, but, very beautiful and very innovative practices came out from people at that point of time, from the people who have been working at the field. And as Evelyn said, like, most of them are like, in some country, it's a very formal structure, whereas in country like India, it's not that much of streamlined to the government programs, like the TV champions over here. I mean, they're really underpaid. I mean, I'll come to that next findings over there. So we had a series of value of the community-led interventions, which was not actually advised, or which was not actually part of any projects, or which was happening because the pandemic happened and it occurred all of a sudden. Like I remember talking with one of the stakeholders during the FZD in India that, they had to do a series of advocacy because the situation was so was so tight that people were not allowed to move, but they suddenly set up a WhatsApp call and they were saying that, we have to go and give these medicines, but then police were over there, the security personnel were over there, they were not letting the people go over there, so suddenly they have to find out with whom we can advocate, and everything was done at, like, at a very instant. It was not planned, but things were done in such a way that, the services get delivered to people. And I remember from the findings that in Kenya, they started not wearing the uniform because it was, creating the stigma because people were not allowed to move freely and all. So all these innovations happened during that COVID, when pandemic happened, and this was all done by the community people. I mean, they were known as lay counselors in Cambodia. In India, they are known as TB champions. In Indonesia, community cadres. Yeah. So, but basically, it's a community people who was leading the interventions at that point of time, just trying to make sure that the people affected by TB were not left, and they were, getting the services that was required. So while we analyze the findings and while we did, these are some of the lessons learned at which we think. What we feel is that the community healthcare workers, whatever the name be, I mean, they are in some country it's formal structure, in some country it is informal structure. But one thing which is common is that they are underpaid. And I mean, forget about underpaid. We were getting to hear stories of how they did advocacy with their politicians and how did managed to bring in food because, they were delivering the medicines at the doorstep, but the people with TB, I mean, they were taking the medicines, they needed nutritions. So, they had to, pay out of the pocket, and during that point of time, they had to do advocacy with the local leaders and all. So, but then they are very, very, very underpaid. But if you look at the Declaration of Human Rights, or even if you look at the WHO guidelines also, it's been very clearly said that we all need to be paid properly for the kind of services we are doing. So this is one very big lesson which we learned while doing the studies, that the amount of the work that the community health workers are doing at the ground level and the amount of the the price, that the money that they're being paid, they're very underpaid. And this is not fair at all. So this is one lesson, big lesson learned that we have learned from this study. And another thing is health systems for TB should be strengthened, because this is one thing again, because when COVID happened, I think many of the things were being utilized and then think, well, it was a pandemic, but I think this lesson should be taken in a way so that when the next pandemic happens, we are prepared, and all these things should be in place, like maybe in a crisis situation or wherever, because in trying to address one disease, we shouldn't be neglecting the other disease, which is that also requires a major importance, equal attention. So we came up with at the end of the study. I mean, if these are just some points that which we have put up over here in the PPT. If you can get the full study report in our website also. So these are some of the way forward that which we have recommended based on the findings from the report and based on the interviews which we have collected and analysis. To NTP is a structured remuneration packages in the form of salaries and benefits for community health workers. So this is one of the recommendation number one, which we feel that should be, implemented at the country level. And then we thought that maybe it would be good to give the specific direction to whom we are saying that. Like to NTP, what we are suggesting is to initiate high-level discussions with donors and politicians on fair remuneration of the people working at the field. To Global Fund or to donor to insist on fair remuneration in Global Fund country programs, and to the community health workers to increase their advocacy on demand for the fair price. And another way forward which we have is a future pandemic plans to include contingency for those. NTP to work with key health security and pandemic response, as well as the Ministry of Finance, Global Fund to finance multi-agency discussions with community participations, community health workers to gather information on key vulnerable populations for feedback into these meetings. Like we have to report it back to the higher people or to the people that what is really happening at the ground level. And another one is diversification of TB molecular diagnosis. I mean, we have to find out ways to expand the ways. NTP to begin consultations to diversify the WHO recognized molecular diagnosis, GF to Global Fund to facilitate opportunities, and community health workers to establish community advisory boards towards this goal. I would like to, I think I would just like to take a point and say that what Dr. Henry was saying, one of the lessons learned, I'd just like to say the digital divide, which happened during the pandemics. I mean, it came out very strongly from our key informant and from our qualitative interviews with, specifically with Indonesia, maybe because this was not, captured by the people in other countries, but it came out very strongly from our key informants with the Indonesia partners that this is a divide which happened because during the pandemic time, everything was locked down, nobody could visit, home visit, and there was very little of in-person interaction, as we all know. So what happened is that people were using most of the digital tools like WhatsApp calls, videos, and all those WhatsApp groups and all. So, but there are people, correct me if I'm wrong, I believe that it's mostly to do with the senior citizens and also people who have belonged to the poverty level, who doesn't have the smartphones and all. So they were all being left behind, and sometimes they would call, there was one interview where the person said, the lay counselor, where he said that somebody had called up, and if it was not during the pandemic, he would have gone to that house and he would have helped that person. But he couldn't go at the time because everything was in lockdown. So I think when we plan for the future pandemic preparedness, we need to have all these things in plan. Like, because we were making use of the digital tools, but at the same time, that is also creating a digital divide. Because to some populations, we are able to give services, but at the same time, we are leaving behind some other populations also. So this is one thing which we have learned from the findings as well. Yeah, I would just like to conclude with the same message that it's time for $5 and excess is all right.
Thank you. Thank you, Archana, and thank you to all the speakers. I have just taken some notes from all that you have presented and shared. I would like to really thank you for sharing all your perspectives, and thank once again, GCTA and team for doing this work, which Global Fund and Commission, but it's been a great learning for us, also for our future policies and for supporting programs and also countries. So a few points that I've taken from this is, yes, I mean, we've seen community engagement is really critical, and it's very important. We have learned this from the pandemic as well. We've seen countries, TB programs being affected, the performance being affected because of the diversification of resources towards the pandemic, but the countries who were able to recover were the ones who had very robust engagement with communities. So we do see community engagement as a very critical component when you're looking at, the holistic TB care and control programs. The use of technology. This has also been quite a game changer for everybody. And during the pandemic, I mean, the use of technology, even by communities, has been an eye-opener that this can really change. You've been talking about WhatsApp, which is one mechanism, but otherwise, all the digital tools and technology have really helped for communities also to connect better. Yes, community health workers, more systematic engagement. We have seen many examples from different countries. One of the examples that we always learn from is from the Ethiopia, where they have a more systematic engagement. They are institutionalized as part of the healthcare systems. They get better paid, better remuneration compared to other countries. But yes, we do recognize it's not about just the global fund, but I think globally we all recognize that community health worker engagement should be more systematic, should be formalized, so that they are paid better for the services that they render, and they deserve it. These lessons learned have been shared with our community rights and gender. We've had inputs from all our divisions at the Global Fund, and we really recognize that this is not just about the Global Fund, though Global Fund globally supports more than 75% of the TB programs worldwide, but there are other donors and players as well who play a key role in this. Yes, there is need for more advocacy at all levels. You need at the ground level, at the local level, you need advocacy at the higher levels, you need advocacy at all the levels. So advocacy is a critical component. It's not just about fighting the TB program and TB epidemic as of now, but also for future preparedness. Advocacy has to be a part of your work that all of us do at different levels. So that plays a great role. I have a question for all the panelists here, but I would like to start with Dr. Tiara Pakasi, who is actually heading the program and has a critical decision maker. And Tiara also has the challenge of how do I include everybody while I take decisions, and also so that you don't leave anybody behind when you're actually taking decisions, and you need to engage with communities as well while you're taking decisions. So one question that I have is, you had a recent stigma assessment which was done in Indonesia. So what are your plans for, and what are your plans for include some of the activities that the assessment report has shown that you would like to address as part of the program? And secondly, the lessons that you have learned from the pandemic. What do you see as one of the key things that you would do for future pandemic, not just to address TB, but as a part of the global health response, as part of the UNHLM, another umbrella of UHC as well. So I would like to listen. Maybe I can give you this mic so you don't have to really stand.
Okay, thank you. What big questions that make me got up. Better than
Sorry
coffee.
for putting you on the spot.
Okay,
So we've
quick
been asked
quick
to follow
answer.
the time.
Yes.
You have to answer me quickly.
Yeah,
For all
okay.
of us.
Yeah.
Thanks.
So actually, we already we have volunteers or cadres is integrated part of all health programs, because besides for TB, it is also, we have we call it the health integrated post that also include cadres. But of course, if we are talking about the uh, remuneration or reward for cadres, then it is not, I mean, it should be also be thought of other ministries and also local government. But so far, we managed to get it, yeah. But of course, with different variation, because again, as I said, health is decentralized. And sometimes in richer districts, then maybe cadres get remuneration better than the other. But I think most of Indonesian cadres work with the basic philosophy of our country, which is the Bhinneka Tunggal Ika and Gotong Royong. So far, I think they're still working with all of their heart. That is number one. And for number two, I think also with regard to our health transformation, I think cadres is also included in the pillar one, which is about the strengthening the primary health care, and also the I forgot the pillar, which pillar, but it's about the involvement of all stakeholders. That is not only for TB, but also for the preparedness of next pandemic, I mean. Thank you.
Thank you.
I hope
Thank
I
you.
make it clear.
Yes, thank you very much. And my last question is to the entire panel representing the communities as well, to see what is your recommendation apart from what we saw on the slides? You know, what is one of the points that you would like to critically ask of everybody around here that could actually play a role in how we could engage with communities better for future preparedness, but also to end TB at the same time? So
Okay, so maybe in Indonesian context, again, I have to say this, that we have related ministries that, and also the local governments. Then we at the NTP, of course, advocate them, and we also work together, of course, the CSO and the academicians to like endorse this movement to make it possible. Thank you.
Yeah, thank you, Daisy. Very quickly about community engagement. One is recognize communities as a valuable partner. Second is invest in building the capacity of the communities. Third is respect the community's view. And fourth, invest to value their time by remuneration or payment or whatever. They shouldn't be expected to give free service. Thank you.
Yeah, all the efforts that we are putting here, coming to Paris, everything we are doing is because of the communities, right? And therefore, they should be not just an equal partner, but a partner that is even prioritized over and above everyone else. And for this to happen, you must invest, and again invest adequately to communities.
I think it's already answered by Desi, but one thing that I want to add is about the community need to be acknowledged. Yes, because when sometimes they what the Archana said, they have to give from their pocket, their own pocket, but no one knows that. But this is the good volunteerism. So everyone need to acknowledge, even the government. So it should be. Um, uh, it's not just the empowerment to give them the capacity, maybe regarding the remuneration and also need to be considered. Okay, thank you.
I think everybody has said that, but I would just like to say that when things doesn't work out and when things happen, when problem happens, and who comes in to fill the gap or who comes in to address the problem, it's a community who comes to do that. And you know, we have got different strategy of public health, private partnership, test method, detect method, but community engagement is a critical. I mean, it has to, it's a critical cross-cutting in all the thematic areas or in all the partners. So we need to continue empowering the communities, and I would like to echo what all others said. We need to invest in community to continue doing that. Yeah.
thank you. Thank you to all the speakers and panelists and audience here. because the paucity of time, we're not taking questions from the audience, but you can put your questions. I think they scan submit a question, but I don't know where they actually go. But just 2 points as a chairperson here today. One is, yes, we need to give a big hand to the communities for the wonderful work that they do, because without them, we cannot fight TB. So this applause is for everybody in the community who's out there and not represented here, but represented by all of you here. And secondly, one request that I have also for the national TB programs is to also invest in communities from the domestic financing and not just depend on international donors to actually invest in communities. The donors are there, but it's part of your community. I mean, you should also invest through the domestic financing in communities because they do wonderful work. I think we need to really acknowledge the work. But this is a request to you. Maybe Indonesia can do things even more beautifully and to invest in communities. So that's the last word. But thank you, everyone. Thank you for your patience. And thanks to the panelists once again.